Renal denervation is a new option for resistant hypertension. In JACC, October 2nd, a cost-effectiveness analysis, and I am with Dr. Murray Esler, Baker IDI Heart and Diabetes Institute in Melbourne. And in CardioSource WorldNews, we've covered the Simplicity trials a couple of different times. This is an analysis in JACC of Simplicity HTN2 data, correct?
That's correct. That was used as the basis for how much you get blood pressure to fall, and then projections were based on that in terms of complication rates.
We have not seen a lot of cost-effectiveness data, so I'm really interested to hear, what did you find?
What we found was it worked out much more beneficial than many other treatments that are currently reimbursed and paid for. The basis of the analysis was to compare the treatment group, the denervation group, with the control group, who were standard of care, look at the blood pressure differential achieved by denervation, and then make projections about outcomes if that blood pressure differential was maintained, outcomes in terms of heart attacks and strokes, heart failure, end-stage renal disease. And you compute all that out, and it turned out that you gain one quality adjusted life year, one QALY, for about $3,000 US.
Which is pretty efficient and effective.
It's pretty darn good.
Are you happy with the numbers? Is this about what you expected, or is it even a little better than you expected?
It's a little better than I expected.
Good.
And there are, of course, a few assumptions in this. It's that the 32 millimeter systolic blood pressure differential will be maintained through lifetime. It's a lifetime analysis. And what we're finding is through to about 3 years anyway, that blood pressure benefit is maintained.
Now, your analytic model, you mentioned end-stage renal disease. Your analytical model differs a little bit from some of the others that have been used, correct?
Yes. In this particular model, there are certain outcomes identified, and there were 6 of them, and it included end-stage renal disease, but the model allowed for interactions and more than one outcome. For example, someone could have a heart attack, heart failure, and end-stage renal disease, all 3, and it's computed into the analysis.
In a small percentage of patients, was it 1 in 4, 1 in 5, there actually seemed to be a cost savings, correct?
There did. Exactly how you set your parameters introduces a certain degree of arbitrariness, and I think that just sounded too good to be true, that it was a cost saving. But with the parameters that were decided on, there was that 3,000 per QALY.
That's pretty good. That's very impressive. And this is in the October 2nd issue of JACC. It's available online. Go read Dr. Esler's paper. And I'm Rick McGuire, the executive editor of CardioSource WorldNews.